Welcome back. Today we will start our lecture on uterovaginal prolapse. It's a difficult topic in general, but I have tried to simplify it as much as I can. By the end of this lecture, you should be able to know the main basics of anatomy of the pelvis and especially the supporting ligaments and fascia for the pelvic organs in the female pelvis. Know the relationship between anatomical prolapse and functional symptoms, including urinary bowel and sexual dysfunction. Know the principles of treatment of prolapse together with potential side effects and complications. So before we start, so in pelvis, there is something which is called pelvic floor muscles, and their main purpose is to support the pelvic organs, which in a female pelvis is the uterus in the center, and in front there is the urinary bladder, and posteriorly it is the rectum. Now, this pelvic floor is made by a muscle mainly, which is called levator ani. Of course, there is fascia as well, but this levator ani is not simply one muscle. It has different components. It has different parts, which include tuborectalis, so extending from the pubic symphysis to the rectum, pubococcygeus, iliococcygeus, and then a smaller muscle posteriorly, which is the coccygeus. So you do not exactly need to remember the anatomy, but just remember that levator ani is the muscle which forms the pelvic floor, and its main role is to support the pelvic organs so they do not slip through it. Okay, so now coming to the topic, what do we mean by genital prolapse? It's kind of a hernia. Okay, so in hernia, what happens is like an organ is prolapsed, right? Same is with genital prolapse. The pelvic organs, they are prolapsed. They descend, okay? They descend from their normal place, from their normal position. So genital prolapse is the descent, and it can happen to one pelvic organ or more than that, of one or more of the genital organs, which can be even urethra, urinary bladder, ureterus, or rectum, and through the pelvic floor below their normal level. So when they just go below their normal position, that's the genital prolapse. Now, for example, this is a normal anatomy, right? So there is a uterus, and this is an anteverted uterus. Okay, so that's the normal anteverted uterus. It opens through the cervix into the vagina, and anteriorly there is the urinary bladder, and posteriorly there is the rectum. Now imagine, due to one reason or another, which we will discuss later, if this uterus descends, becomes down below what is expected, right? So from its normal position, it comes down, then it is uterine prolapse, okay? So, and usually there may be, we usually call it uterovaginal prolapse, because when uterus comes down, there is some element of vaginal prolapse as well. Now we will use these different words, okay, different terms. So in normal anatomy, you know what happens in normal anatomy. Sometimes there is bladder prolapse, the urinary bladder prolapses. This is called cystocele. Cystocele is the term, okay. So, and see, there is vagina, right? So uterus opens through the cervix into the vagina. So urinary bladder, if it descends, we may see a bulge in the anterior wall of the vagina. That's called a cystocele. The opposite is rectocele. So if the rectum descends, what we will see, it will make a bulge in the posterior wall of the vagina, and so on speculum examination we will see a bulge there. So this is called rectocele. Okay, this is the general term. And uterine prolapse means all of the uterus is coming down, and usually it is associated with uterovaginal prolapse. Okay, and sometimes what happens is, for one reason or another, when the uterus is removed at hysterectomy, so the cervix and uterus are removed, but vagina is still left behind, right? And vagina is not taken out. Okay, so but vagina is stitched at the top. Okay, so that is called the vault, the top of the vagina after hysterectomy when it is stitched. And why it is stitched? So that the intestines, they do not come out, right? They do not come out through the vaginal opening. So that's the reason. So when it is stitched, that is called a vault. And sometimes even that vault can prolapse. Okay, so that condition is called, the top of the vagina can prolapse. That's called the vaginal vault prolapse. Okay, so yeah, so it can come out. Okay, so what is the cause, etiology? What can cause genital prolapse? So it comes under the gynae specialty, which is called urogynecology. Okay, so it comes under urogynecologists usually, although general gynecologists can also deal, but it specifically comes under the specialty. So difficult delivery, especially with instruments. So if a woman comes with genital prolapse in history, we have to ask about her parity, were her deliveries instrumental, like instrumental deliveries, and then what was the size of the baby? Were they big? Were they stuck? Okay, so if it was difficult deliveries, instrumental deliveries, difficult forceps, and repeated vaginal deliveries, that's a risk factor to develop genital prolapse. Okay, then aging, because so it's a disease of the, usually, yes, in younger women it can happen, but it's more commonly in the older women, and it's because there is no estrogen. So once estrogen support is lost, the connective tissues become lax, and then there are more at risk of developing genital prolapse. And then sometimes it runs in families, for example, Ehlers, Danlos syndrome, or connective tissue disorders, or Marfan syndrome, where the connective tissue is lax. Okay, and then there are some women who, because of their profession or even their responsibilities, for example, women who are heavy weight lifters, or even in their daily activities when they have to lift heavy weights. Okay, even women working maybe on farms, or their responsibilities, okay, if they have to lift weight. Also, what I have not mentioned here is women who have chronic diseases, for example, chronic constipation or COPD, for example, or where there is chronic cough for one reason or another. Okay, family history is related to these connective tissue disorders. Yeah, precipitating factors, anything which increases intra-abdominal pressure. For example, even if there is a big mass, right, big ovarian cyst, benign, it has been there for a while, and then it just increases pressure. So anything which increases intra-abdominal pressure, it can be even chronic cough, chronic constipation. Okay, so, and anything which increases the weight of the uterus. Okay, so for example, if there is a big fibroid, right, and it is cause pressure. Okay, or rarely a large cervical, a very huge cervical polyp which is causing traction. Okay, and then obesity. Yeah, obesity is a known risk factor. Smoking, yes, and mainly it's associated with, yeah, it may be associated with weakening of the connective tissue, but mainly it's maybe associated with chronic cough, pulmonary disease, chronic constipation because of chronic straining, recreational or occupational activities like frequent or heavy weightlifting. This is just kind of a repetition. What are the supports of the uterus? You do not need to remember each and everything here. Okay, so but uterus, see, it is connected by different ligaments to the surrounding structures, and that's why its position is maintained, right? It does not slip through the pelvic floor. So it is wrapped in different kind of, surrounded by ligaments. Okay, and yes, there is pubocervical ligament, there is uterosacral ligament, so but what is the main support of the uterus? It is the transverse cervical ligament. It is also called cardinal ligament, or it has another name, McEnroe's ligament. Okay, but usually it's called, the most common name is cardinal ligament. They all mean the same. So transverse cervical ligament means it's transverse bilaterally, okay, on both sides. And it's also called cardinal because that's the most important. Now there are some ligaments in the pelvis which are big in size, but they do not have any role in supporting the uterus. For example, broad ligament. Broad ligament is a very broad, right? It's very broad, but it technically supplies minimal or no support to the uterus. Okay, so if you have to at least remember two names, that's the transverse cervical ligament and the uterosacral ligament. Okay, so now at different levels, there are three levels at which the uterus is supported. First one is the cardinal or the transverse cervical or the McEnroe's ligament and the uterosacral ligament complex, like together. Okay. Level two, the pubocervical and rectovaginal fascia. And the third one is really down below, right? The pubourethral ligament anteriorly and the perineal body posteriorly. So remember, perineal body is a many muscles fuse there. Okay, and it's the level three, quite low down. Okay, so okay, now I will stop here and rest we will discuss in the next part of the lecture.